Okay. So, we're going to talk about pediatric sleep apnea. You guys had a talk earlier today about OSA in general with a focus on adult sleep apnea, presumably. And was that like followed by some respiratory monitoring talks? Did I get that right? Or monitoring airflow?
Think she
That's later. Say again?
She did.
Oh, she canceled it. Oh, rats. Okay. Right. Well, if anything's unfamiliar, just stop me, and this is meant to. So ask questions, Nate. Um, I'm going to minimize that. Okay, so sleep apnea is one of the most common medical disorders in the adult population. I'm sure you guys have heard the stats, right? 40, 50 million Americans have sleep apnea, potentially 10 or more percent of the general population. And in certain groups, people with obesity, for example, people with certain cardiac issues, the rates go way up 50, 60, 70%. Kids have apnea too, but it's much less common. So the prevalence that you're going to read about most typically is anywhere between 1% and 5%. Depends a little bit on where you slice it, like what's sleep apnea, what's normal. But a good rule of thumb is 5% or under. That being said, the rates of sleep apnea are going up because the rates of pediatric obesity are going up. The traditional teaching, and we'll get into some of the details, but the traditional teaching is that adult apnea and pediatric apnea are kind of different animals. At the end of the day, the physiology is still dynamic upper airway collapse, right? But how that happens and how it manifests and also how it's treated historically have been kind of different. That being said, especially in kids who have obesity, especially teenagers with obesity, we're seeing a lot more adult-like patterns of OSA. So you kind of use what you learned from your adult OSA training, use what you learned from your peds OSA training, and see which is kind of the best fit. Important things to know, we, as with adults, diagnose pediatric sleep apnea by PSG, but the scoring criteria are different. The cut points, like the severity ranges, are different. And of course, the treatment options typically are different. You guys by now are very familiar with the AHI, right? The apnea-hypopnea index, which is just a rate, right? It's apneas plus hypopneas divided by total sleep time. In kids, we use the AHI as well, but you will very commonly see the OAHI, which is the obstructive AHI, which very simply is obstructive apneas plus hypopneas or obstructive hypopneas, not central apneas, divided by total sleep time. The reason we do that is that kids tend to have a greater predilection for central apneas, physiologic central apneas, than older adults do. Being a little bit Socratic, do you guys have some thoughts about why that might be? Why would a child be more likely to have physiologic central apneas than an adult? Could be, yeah. So just for the people in cyberspace, Dr. Katana suggested the respiratory control centers are essentially immature, and that's definitely true for premature babies. We see a lot of apnea of prematurity in the NICU, for example. Maybe true for kids who are not developing typically. They have sort of forever dysmature respiratory control centers. So that's definitely true for a fraction of kids. How about for like a typically developing kid? And I'll bias you a little bit with the physiology. So as you guys know, the gas that primarily drives our respiratory rate is CO2. And so if the CO2 gets too low, that's going to induce an apnea. And that's going to be a central apnea, right? Lack of respiratory drive. So how does that inform your answer? You're not supposed to know this, by the way. I'm just curious to have you think about it. Yeah. Yeah, I think all of those things play a role. I suspect the receptors are probably mature, but as you mentioned, there's a lot of interactions between like the HPA axis, the neuroendocrine system, and respiratory control. Estrogen and progesterone are well known to have sort of respiratory stimulating effect. Testosterone may have sort of the opposite effect and induce more loop gain physiology. So that probably plays a role. In my mind, the way I think about it is it's down to pure mechanics. Kids have less dead space, right? So when a child breathes, especially if they take a big breath, like after an arousal, they're going to blow off their CO2 much more quickly because they're not ventilating dead space. So the swings in normocapnic versus hypocapnic happen much more quickly and readily in kids. And that as complicated as we can get because I'm not a pulmonologist. But so what you'll often see in kids, especially after an arousal for sleep, they have a big hyperpnic breath, they blow off that CO2, their CO2 levels drop, and then you have to wait for those levels to rise up again until they reach the apneic threshold. So for that reason, we tend to ignore physiologic central apneas and focus primarily on the obstructive AHI. Now, kids can definitely have pathologic central apneas. Kids with various sort of neurologic issues, TBI, severe brain injury, et cetera, et cetera, et cetera. But for the most part, typically developing kids, when they do have central apneas, they're physiologic, or you'll see them after an arousal. And as you see lots and lots of sleep studies, you'll sort of instantly recognize when that's happening. Okay. So the other thing to understand is that the cut points for pediatric OSA are different. I'm sure you're all familiar with in adults, 0 to 5 would be normal, 5 to 15 mild, 15 to 30 moderate, 30 plus severe. In kids, we use slightly different cut points, again, using the OHI. So an OHI between 1 and 5 is considered mild obstructive sleep apnea in kids. 5 to nobody really agrees. Here we say 15, some people say 10 would be moderate. And then either 10 or 15 plus is considered severe apnea. Just like with adults, you'll want to look at other metrics to sort of decide on what the true severity is, things like the hypoxic burden and so on and so forth. But technically speaking, the severity is determined by this one sort of unidimensional metric. Okay. OSA can affect kids sort of across the developmental spectrum. Obstructive apnea is rare in infants. I mean, it can happen. Kids with congenital craniofacial differences, neuromuscular disorders leading to poor tone, et cetera. That, of course, it can happen, but it's most common beginning maybe around 2 years. It sort of peaks in the preschool years, and then in non-obese kids sort of falls off through late school age into the teen years. But it can be present at any point in the developmental spectrum. Roughly 10% of kids have habitual snoring. So there's not a one-to-one correlation between snoring and sleep apnea. And in the general population, anywhere between 10 and 30% of snorers have OSA. So the majority of kids who snore do not have sleep apnea. And one of the kind of key learning points of pediatric OSA is, frustratingly, there's not great symptom sleep study correlation. So we ask about all of that, we take a good history, but at the end of the day, you're much more likely to get a sleep study in a child than you are for an adult at a lower level of symptomatology. The way I like to think about it is in adults, you're trying to rule in apnea. In kids, you're trying to rule it out. Okay. I think we talked about this. OSA prevalence ranges between 1 and 5%. But only about half, maybe up to 65% of kids in whom you suspect OSA clinically end up having significant OSA on the sleep study. And so there is a quandary sometimes about what do we do for this kid when our clinical impression says one thing, the testing says another. So we'll talk about that. That being said, the night-to-night reliability of PSG in kids, though not perfect, is pretty good. We worry about this, right, because the cut points are so low. An obstructive HI of 1 or greater gives you apnea, and you can imagine oscillating 1.1, 0.8, 0.9, 1.5. But in reality, especially at the more significant levels of apnea, there is good retest reliability. One of the most significant risk factors for OSA in kids is enlargement of the tonsils and adenoids. And I would say in the typically developing pediatric population, this is like the #1 cause and also the #1 target for intervention. So when you're doing an exam, really in anybody, but especially in kids, paying attention to what's going on in the back of the throat is important. There are 4, or I guess 5 if you count 0, tonsil positions or grades. And as you progress through the year, you'll get more and more familiar with how to grade these. But the basic idea is if you look at the anatomy, here are the tonsillar pillars, extension of the soft palate, so tissue and musculature, and just peeking beyond those are the tonsils. I generally consider tonsil size 0 to be absent. This is an older textbook here, but I think for your purposes, 0 would be absent, surgically removed, not visible. 1+ tonsils are just beginning to peek beyond the tonsillar pillars. 2+ tonsils are fully visible beyond the pillars, but they're occluding less than 50% of the lateral distance. So if you drew a line horizontally between the tonsillar pillars, 2+ tonsils are getting at least 1/4 of that, but less than half. Once you're up to half, those are 3+ tonsils. And once you're above 75%, you're at 4+ tonsils. You'll also hear those referred to as kissing tonsils. And those are the kind of tonsils you can see from like across the room. The kid opens their mouth and they're just sitting in there. Other features can be sort of useful soft signs. So mouth breathing, even during the day in the exam room, as you can see in the sort of these kids here on the right and this kid here on the lower left. The reason this can be helpful is that this is often a sign of nasal obstruction, nasopharyngeal obstruction, because of adenoid hypertrophy, and kids will often develop this sort of reflexive oral breathing. This is interesting because it's both a chicken and an egg. So yes, it's the egg insofar as it's the response to the nasal obstruction, but it's also it can also cause further issues because kids, as they go about their young lives developing with constant oral breathing, their tongue position is different. The palate, the hard palate, may actually become more narrow and high arched. Consequently, you have less room for the tongue with the mandible in the closed position. And so oral breathing can beget worse upper airway obstruction over time. So I would say this is probably an under-recognized issue in pediatric OSA, but it's one of the areas that we try to target with early intervention, whether it's through adenotonsillectomy or orthodontic and or dental intervention, and or something like speech-language therapy. Unfortunately, those latter 3 are underutilized, but optimizing nasal breathing in kids goes a long way beyond just clearing the way for lack of obstruction. The other thing we look at, of course, in kids and adults is the baseline degree of airway patency. You're probably familiar with like the Friedman palate classification. We will often use the Mallampati score in sleep medicine. We use that in pediatrics as well. So I love asking this question. How do you assess the Mallampati score?
Depends which one you're using.
Okay, yeah, let's say the modified Mallampati. Yeah, okay, love it. Do you ask them to say ah? Yeah, you guys are too smart. Okay, I have nothing more to teach you. Yeah, no, I mean, the key point, as you guys already know, saying ah will elevate the palate, right? And so that will artificially show that there's more room in the oropharynx than there actually is. So in the typical Mallampati or mollified Mallampati, you're either having the tongue at rest or sticking out, but you're not having them elevate the palate. And the basic idea here is it's measuring the superior inferior distance basically from the base of the tongue to the uvula, right? A class 1 airway, you can see the entire uvula, including the tip. A class 2 airway, the tip is occluded, but you can see most of the body of the uvula. A class 3 airway, you can see only the base or root of the uvula, but the soft palate is visible. And in a class 4 airway, which is a lot of what you're going to see in adult OSA patients, the soft palate's fully occluded, only the hard palate is visible. We don't have a great sense of the correlation between Mallampati airway score and sleep apnea in kids, but in adults, there's a very clear correlation. A class 4 airway gives you like a 65% pretest probability of having OSA. Okay. Let's pretend this is being done correctly in correlation with the Mallampati evaluation. What Mallampati score would you give this kid, and what tonsil grade would you give this kid?
6+4.
Uh-huh. +4 tonsils, agree. Essentially touching, they're displacing the uvula, actually. Yep. How about one?
Like a speed.
Yeah.
Or 2, maybe 2.
I agree. Somewhere between a 1 and a 2. We should ignore the tongue depressor
Right,
there,
yeah,
which is clearly biasing these things. But if we only looked here and we assumed this were being done in following the Mallampati, technically I'd say 1 actually, because you can see a little bit of black space. Yeah. And that's common in kids. Kids tend to have open airways. If there is a problem, it's a pair of big old tonsils. Okay. In kids, the point of maximal narrowing in the pharyngeal space is where the adenoids and the tonsils overlap in this dimension. So if you drew sort of a diagonal box, this is the narrowest point of the entire upper airway. And in kids, the point of highest resistance. So couple that with the fact that kids tend to have more sort of distendable, floppy airways, and you've got a recipe for collapse, for obstruction. Okay. Couple of important points. So OSA in kids needs to be diagnosed by a sleep study. Clinical history can point you in that direction, but there's not a perfect one-to-one correlation. The positive predictive value of the physical exam, meaning, narrow upper airway by Mallampati score, large tonsils, is only about 45%. So again, we're in the mindset of ruling out OSA as opposed to I have a high clinical suspicion, I'm going to rule it in. We, meaning the American Academy of Sleep Medicine, are working on new position statements for the role of home-based sleep studies in kids for diagnosing OSA. But the thing to understand at this point is in the vast majority of cases, HSAT should not be used for pediatric OSA diagnosis, and an in-lab study should be used. Does that mean you absolutely can't? No. I mean, if you've got a 12-year-old with autism, who's overweight, snores, gasps, and chokes all night, and they absolutely will not tolerate the EEG sense, fine, do an HSAT. It's better than nothing. But as a general rule and on the boards, you want to diagnose pediatric OSA with a PSG. You can also get more than just OSA, right? You're looking for sleep disordered breathing as the broad spectrum. It can pick up on hyperventilation, periodic breathing, which is reasonably common in kids. Additionally, we tend to see more quote unquote neurological sleep issues in kids. Pediatric epilepsy, for example, during sleep's way more common than epileptiform discharges in adults. I would say one of the areas of greatest discomfort for incoming sleep fellows is how do I identify these abnormal things on EEG and start with the kids. And once you know what an epileptiform discharge looks like, you won't miss it. But they're so rare in adults that you might go the whole year and see a couple, but you read enough pediatric sleep studies, you're going to see a bunch. Okay. I'm sure you're familiar with this general concept now, and you certainly will be over the course of the year. So the OSA diagnosis is made essentially the same way it is in adults. We're looking for an interruption in airflow that results in either an arousal from sleep and or a disturbance of gas exchange, namely oxygen desaturation. We're scoring each of those, we're adding them up, and then that becomes your AHI. Subtract out the central events, that's your obstructive AHI. So what kind of event would that be? And if you haven't had this teaching yet, tell me and we'll go through it. But kind of event.
Obstructive.
Okay, obstructive what?
Sleep.
Yeah. So I'm hearing efforts there, apnea, yeah, so it's an obstructive apnea. So the way I usually look at respiratory events is one, decide if it's an apnea or a hypopnea, right? Have you guys had intro to scoring yet? Am I going to?
Not
Okay.
that far.
Okay. Okay. So you'll definitely learn a lot more about this, but the basic idea is one, by how much does the flow drop? I have some slides on this. If it drops a little, hypopnea. If it drops a lot, it's an apnea. And there are percentage criteria for each of this. Okay. So then if it's an apnea, then you go on to decide, is it obstructive or central? And you already mentioned the presence of ongoing effort here in the chest and abdomen, despite the lack of airflow, it tells you it's an obstructive apnea. Okay. Also, this results in very jittery, a disruption in sleep and arousal. You can see that by the sudden change in the EEG tone, followed by a large increase in the chin EMG. So that's an analog of like your skeletal resting muscle tone, followed by a return to sleep, followed by more respiratory events. Okay. All right. So nitty-gritty stuff. When we are looking at kids, if they're 13 and under, we should use the pediatric rules, and we'll talk about what the rules are. 13 to 18, you have the option of pediatric or adult scoring. 18 and above, you want to use the adult scoring. So there is this gray zone, 13 to 18, and so you're going to see something different at every site. In your own practice, you're going to decide how you want to apply it. But here at Metro Health, we've decided anybody under age 18, up to 17.999, is going to be scored using pediatric criteria just for consistency. That being said, there's nothing magical about turning 18.0 and your physiology, switches over to adult physiology. So it's very much a spectrum. But as a rule, we apply pediatric scoring criteria to 18 and under. The two standard devices that you use to measure airflow in a sleep study, and again, forgive me if you haven't heard about this yet, would be a nasal pressure sensor and a thermistor. Is that ringing any bells? Okay. Good. Okay. Sure. Okay. Okay. But you've heard the words. All right. So this, of that. Okay. This in the upper right here is an example of a nasal pressure sensor and thermistor setup. So this is standard in adults, and we try to do this whenever we can in kids. But as you can imagine, tolerating this in a 3-year-old is challenging. So we'll often use a combined sensor. Here we use one by Diametics in little kids, and that's what it looks like. It's just a little stick-on on the filter. So either way, you're still going to get a pressure-based airflow measurement and a temperature-based airflow measurement, and they're different. Again, you may or may not know this yet, but if you're scoring an apnea, do you score it off the nasal pressure sensor or the thermistor sensor? Yeah, okay.
You mentioned it.
Good, okay, good. Do you know why? So, and again, I think you guys are going to hear more about this later, but the nasal pressure sensor signal changes as the square of the airflow. So it's going to drop off very quickly. The thermistor signal changes linear with the temperature change. So what that means is when the airflow drops, the nasal pressure sensor drops off to 0 very quickly, right? Because you're hitting that sort of horizontal asymptote because it's decreasing as the square. Whereas the thermistor is going down linearly, and so it's going to take much longer, a much greater decrease in airflow before that thermistor hits 0. So now if we apply that to the question, we score apneas on the thermistor. You can imagine a scenario where there's still some airflow, you're still getting a thermistor sensor, thermistor signal, but your nasal pressure sensor is 0. So it's only when the nasal thermistor sensor is down to 0 or greater than 90% reduction that you count it as an apnea. Okay. And which one do you score hypopneas off of? Which sensor, I should say? Yeah, the other one. And the reason for that is it changes as a result of the square and flow. So it's much more sensitive, and you get a much better sense of flow limitation. Okay, so that's true in adults and kids. But in kids, you're also likely to see this dimetic sensor. You're still going to get those same flow tracing. It's just a little harder to see flow limitation. Okay. Questions about that? I realize that's like super nitpicky.
So, you mentioned the hypopnea definition suits.
Yeah. Yeah.
So, it's different.
Yes. And as soon as PowerPoint cooperates, okay, so here we go. So there are different duration criteria for respiratory events. The biggest difference is in central apneas, but there are differences in obstructive apneas, central apneas, and hypopneas. But the biggest difference is central apnea. So, okay. Just like adults, if you're looking at an apnea, you want a drop of 90% or more in the airflow signal of the thermal sensor. That's the thermistor, right? Okay. Here's where things start to get a little different. The duration of the drop lasts at least the minimum duration. Okay, we'll get to that. And then it's either obstructive, central, or mixed. Okay. So right now, that sounds exactly like adults. Where things are different, let's start with obstructive. Meets the criteria for apnea, and it's at least the duration of 2 breaths. And it's associated with respiratory effort. That's the same as adults. So duration in kids needs to be at least 2 breaths. What is it in adults? 10 seconds, yeah. And the reason we use 2 breaths is kids have higher respiratory rates. They might get 4 breaths in 10 seconds. But that's the first point. We use a number of breath criteria when we're scoring it. But otherwise, an obstructive apnea looks the same in kids as it does in adults. Here we go. Central apneas, this is where things get a little bit different. So a central apnea in adults, right, is just 10 seconds, and there's no airflow, and there's no respiratory effort. In kids, it's a little more complicated because we wanted to make sure that we're really only paying attention to the central apneas that mean something. We're not paying attention to those short physiologic central apneas that kids have a lot of anyway because they don't have a lot of dead space. So if we're scoring an apnea as central, it needs to be a 90% or greater drop. Okay, we know that. There needs to be absent inspiratory effort. We know that. And it needs to meet one of these following 3 things. it either has to be more than 20 seconds, really long, or it has to last 2 breaths and cause an arousal or a 3% DSAT, which is like a hypopnea. Or it lasts 2 breaths and causes a drop in heart rate under 50 a minute, or if you're an infant, 60 a minute as bradycardia. So in other words, in kids, those central apneas need to have some kind of physiologic consequence, whereas in adults, if they happen, you score it. So this is the biggest difference between pediatric and adult scoring. And then just to round things out, hypopneas. So just like in adults, you need a 30% or more drop in the flow signal of the nasal pressure sensor. But if it's more than 90%, it's apnea. And a 3% drop in SpO2 or an arousal. Okay, so that's pretty much the same. The only difference is it lasts for 2 breaths as opposed to 10 seconds. Did you guys learn about the difference between 1A and 1B hypopneas or CMS and ASM hypopneas? Okay.
You mentioned about the AUP, but he said ASM definition is different.
Yes.
CMS.
Yeah.
Same as the desaturation is 4%.
Correct. Yeah. And ASM is 3% or an arousal. Yeah. So 1A is the ASM criteria, 1B, this is how it's listed in the scoring manual. 1B is CMS criteria. And it's stupid, but we need to report both because some insurance plans still look at CMS and we want people to get therapy if they need it. Okay, so the important thing to know here is there's no CMS hypopneas in kids. It's all ASM. It's 3% or a DSAT, because asking a kid to DSAT by 4% is asking a lot. It doesn't happen in most cases. Okay. And then lastly, this is optional, but you'll see it, so it's important to know about. There is such a thing as an obstructive hypopnea, which is most of them, and a central hypopnea. Scoring these is optional. Most labs do not score them. Telling the difference is kind of arbitrary in many cases. But the idea is a hypopnea is obstructive if it has any of these 3 things. If there's snoring during an event, or increased respiratory flattening of the nasal pressure, it's called flow limitation, or if there's thoracoabdominal paradox during the event. If it has any one of those, it's an obstructive hypopnea. If it has 0 of those, it's a central hypopnea. But most of the time, you're just going to see hypopnea. Socratic question again, why would thoracoabdominal paradox suggest obstruction?
You're working with effort in relation to like having an obstructed flow. So
Yeah.
then you go up and down.
Yeah, exactly. So again, I'm not a pulmonologist, but my sort of simple-minded way of thinking about it is you're breathing from the diaphragm, right? So you breathe in, the diaphragm stretches, the abdomen moves out. You've got an open airway that's going to pull air in. It's creating a vacuum, right? Makes a vacuum, pulls air in, so the chest rises as that air flows in. And then when you breathe out, diaphragm relaxes, the elastic recoil happens, chest goes out. So in normal breathing, chest and abdomen are moving in tandem. If you introduce an upper airway obstruction, you're still moving the diaphragm in and out, right? So you're breathing in, here it goes, but you're generating negative pressure, but that negative pressure can't pull air in. So the chest goes down. So you'll see the opposite kind of movement in the chest and the abdomen. That's more common in kids, but you can see it in adults, especially in REM sleep, because you lose all your intercostal muscle tone. Okay, but if you see that, it's a good sign you've got obstruction. Okay, hypoventilation. Have you learned about that in adults yet? Okay. Oh, okay. Okay. So I'll just spend a little bit of time on this then. But I mean, hypoventilation essentially is a problem of inefficient gas exchange, right? There can be several different reasons for that. It could be because you're obstructing, right? But you can have a totally clear and open airway and still hypoventilate just because you're not getting enough inflation, you're not getting enough air mixing in the alveoli, essentially, right? So your CO2 levels go up. Your oxygen levels may or may not go down, but the high CO2 is kind of a hallmark of hypoventilation. In adults, you'll learn about this tomorrow. There's two ways to define it. Your CO2 is either greater than 55 for 10 minutes, or 10 minutes of sleep, or it's 10 millimeters of mercury above your awake CO2, and also greater than 50 for 10 minutes. Okay, so 55 versus 50, those are the magic numbers in adults. In kids, the target is 50, so forget 55, and it's percentage based. It's 25%. Why can't we just be consistent? But that's what it is. Essentially, we have a lower threshold for diagnosing hypoventilation in kids. Okay. Having said that, when you do see hypoventilation in kids, it's more common to be obstructive hypoventilation than like a neuromuscular or respiratory drive type of hypoventilation. And you'll see these sleep studies with just like constant flow limitation, maybe not many events, but constant flow limitation. That's impairing gas exchange at the level of the alveoli, and you'll have these sort of 50, 51, 52, 53 CO2 levels. That is not necessarily a kid that needs BiPAP or a trach, or you take the tonsils out, eliminate the obstruction, and that kid is probably going to stop hyperventilating. But for that reason, it is recommended to monitor CO2 for all kids undergoing diagnostic PST. We try to do it for all kids. It's mandatory here under 4. It's sort of optional above age 4, but the ASM recommendation is you should consider it for any diagnostic PST in a kid. Okay, so we're going to transition from diagnosis to treatment, and this half will be much quicker. I know we're close to the end of the hour here, but before we transition, questions about diagnosis? It's one of them. Yeah, the two big reasons, well, 3 big reasons. One, it's just not valid. But 2, you don't have a good way to measure CO2 at home. 3, you don't have a good way to measure sleep. So most home sleep apnea testing is measuring oxygen desaturations. Kids tend not to desaturate a lot, especially compared to adults. They tend to have a lot more arousals. And most home sleep apnea tests don't pick up on arousals. Some can, you'll hear about like the yeah, but the PAT-based or PPG-based technologies like WatchPat will have an analog of arousals. So that's probably what we're going to see implemented for pediatric HSAT. But the big reason not to use an HSAT in kids is that you don't get a good sense of arousals and can't measure CO2. Okay. Treating OSA, first line of therapy is adenotonsillectomy. The efficacy success rates are close to about 80%. Watchful waiting may be an option in cases of mild apnea, minimal symptomatology, but there are other options as well. CPAP is generally considered a second or third line of therapy. Patients who have not done well with surgery or for one reason or another aren't a candidate for surgery. And there's also medical treatment options that are pretty commonly approved. So a lot of what we currently understand in practice about the treatment of apnea is based on the trial that was completed in large part in Cleveland, but elsewhere across the country, which is called the CHAT trial, Childhood Adenotonsillectomy Trial. So this is a study of close to 500 kids, ages 5 to 9. And they were randomized in, so they all had apnea. They were randomized to adenotonsillectomy right away or watchful waiting. And at the end of the assessment period, now I'm blanking, 4 months, 5 months, something like that, they compared differences in a number of metrics. The key outcome measure in the chat was this kind of compound neuropsychiatric outcome measure, the NEPC. Yeah, and they actually did not see a difference between adenotonsillectomy and watchful waiting. However, there were lots of meaningful differences and statistical differences in quality of life measures, subjective child and parent report of like behavior and so on and so forth. So the general idea is whatever is being measured here, attention, executive function, et cetera, if it's changing, it's probably not changing within the short period of time. I'll defer to our developmental colleague, but I don't think you would expect it to change in that period of time.
Right, and I think a lot of like cats is also it's similar. I think the problem I have with some of these studies, I mean, I just say the Carol Rosen, but but I think in terms of neurobehavioral metrics, when you're looking at them, sometimes when they report it, and I don't know if it has to do with just the data set, just the outcomes, but they'll pick part of the testing that you wouldn't expect them to report on. Like that would be not the most sensitive part of the test that you would expect to see. And so I had actually did a presentation for ATS with Dr. Prero, and they didn't have their like neuropsych person, so they asked me to make like kind of talk about the metrics. And it was interesting because they did something called the CBCL, the Child Behavior Checklist, and they only included internal versus external forces, which is but that's like really not specific, and it was actually opposite of what you would expect if you were to look at subcategories like anxiety, attention deficit hyperactivity, impulsivity.
External.
It's interesting. Yeah, I don't know. I wasn't allowed to ask the question because nobody knew the answer. So
interesting. Yeah, it's one of the major pitfalls of psychiatric neurobehavioral research is you can only measure what you choose to measure.
Right.
And often you've got two options, right? You either set out ahead of time what you're measuring, are right or you do sort of factor analysis later on and you let the statistics tell you what matters, but that may not be concordant with what clinically matters to us. So for what it's worth, I agree. I think that that was a big issue and one of the major drawbacks of CHAP. But that being said, I think there still are important outcomes that matter to families and children that are just a little more nebulous, subjective, but nonetheless are things that you're going to hear about in clinic. Quality of life, symptom reduction, less snoring, less restless sleep, better behave during the day. Interestingly, I don't think the teacher rating of behavior was significantly different, but the parent certainly was. So, nothing's perfect. Nonetheless, we still maintain adenotonsillectomy as the first line of therapy, pediatric OSA. Having said that, another very interesting kind of sub-finding that came out of this and was published the year after is that 40% of kids in the watchful waiting group spontaneously resolved by PSG. So the big question there is, well, if 40% of those kids who we did nothing to resolve, should we in fact not be performing adenotonsillectomy as aggressively as we are in these kids? But the key takeaway there is two things. One, symptom improvement basically never happened in those kids. Even though their apnea improved by the numbers, the symptoms that the family was noting and that the kid was experiencing really didn't change even after the numbers dropped. So that's, I think, an important example of that discontinuity we were talking about between symptomatology and what the sleep study is showing us. So take it with a grain of salt. In other words, kid comes to you in clinic, they are very symptomatic. It's almost never the right answer to say, let's just wait and see. Similarly, if they've had their tonsils out and they're still symptomatic, it's almost never the right answer to say, well, your numbers got better, I'm not going to treat you. So you try and correlate the numbers and the symptoms as best you can, but if one is going to win out, you go with the symptoms in kids. Okay. Similarly, the spontaneous improvement was mostly in kids with mild baseline OSA. It was mostly in kids with a normal BMI, and there were some ethnic/racial disparities in terms of that as well. African-American kids did not have nearly the same amount of spontaneous improvement as non-African-American kids, and we don't really know why. Okay. We're getting close to the end here. Table here just kind of quickly summarizing the key differences between pediatric and adult OSA. The basic thing to pay attention to here, and we've known this for a few years now, is children with obesity look more like adults with apnea than they do kids with apnea. So you're going to see a lot more snoring, gasping, choking, daytime sleepiness, a lot less externalizing behaviors, hyperactivity, acting out, etc. You're going to get a lot lower rate of cure with an adenotonsillectomy. Doesn't mean don't do it, at least in our current treatment paradigm. But I always counsel those families differently when the BMI is 99th percentile. Look, I think those 4+ tonsils need to come out, but there's a good chance that your apnea is not going to be resolved. It's going to be better, but there's a good chance it's not going to be resolved. So sort of aggressive lifestyle management and counseling is really important in these. Success rate of those things is a different story. It's near zero, right? But we still got to try. Okay. That being said, PAP therapy is an option in kids. Typically, I would consider PAP therapy in severe apnea if they've already gone through a tonsillectomy and it hasn't worked fully, or for some reason they're not a candidate for a TNA, hemophilia, or something like that. So the kids who are more likely to require PAP therapy are those with significant obesity, craniofacial differences, neuromuscular weakness, etc. In kids, you generally want to titrate them, bring them back into the sleep lab, do a CPAP titration, although there's mounting evidence that at least in older kids who are developmentally typical, an auto-adjusting CPAP is perfectly appropriate. And actually, titration studies tended to overestimate the pressure requirements compared to auto-PAP in those kids. So in my own practice, 12-year-old, small tonsils, BMI's 90th percentile, there's a good chance I'm just going to recommend PAP for them if they're symptomatic enough. Different story in a young kid. Still going to try and get those tonsils out first, but if they're still symptomatic, we might think about PAP therapy. There's pretty good evidence showing that whatever neurobehavioral outcomes you're measuring, and people have looked at a lot of different ones, they tend to get better with PAP therapy. One other thing to consider is, especially with long-term use in a younger kid, your facial bones are still developing. And so constant pressure from the mask in the same place for 8 or 9 hours a night may lead to differences in bony facial growth. So we try and switch out mask interfaces and keep them as loose as possible, every 6 months or so in kids who require long-term PAP therapy. Risk versus benefit, it's usually better to use the PAP. I wouldn't not use it because of that, but you do need to be careful that you're not inducing, maxillary underdevelopment.
So do you allow for more leakage with those kiddos?
I'm more open to that. Yeah. It can't be too much because then they're going to rip it off overnight. Exactly. But if it's 10, 15, 20 liters a minute,
okay,
fine. Yeah. Okay. Last few slides here. There is a middle ground between watchful waiting and aggressive surgical or PAP intervention, and that's pharmacotherapy. So we use a fair bit of montelukast and nasal steroids in kids who have mild or moderate apnea and are symptomatic. If they're mild and they're asymptomatic, you might just wait, right? But if they've got some symptoms, and perhaps if the family is reticent to move forward with surgery, medications are a reasonable option. This is especially true for kids at that sweet spot of 3 to 6 years of age. Reason that's the sweet spot is that's the point at which the tonsils and the adenoids are at their largest relative to the size of the airway. If you can get that kid past that size, that space where the tonsils are at their largest, their airway caliber is going to increase, their tonsil size is not going to increase, and so their obstruction is going to improve. That being said, if they're symptomatic, you often don't feel comfortable saying, hang out for a year. I mean, that's a lot of development happens in a year. So that's where medical therapy can come in. So we'll often prescribe 4 months, 6 months, even 12 months of medical therapy if it's working for kids in that sort of early, like late preschool, early school age range to try and get them past that point of maximum airway obstruction. If it doesn't work, they're still symptomatic, then you can proceed with the tonsillectomy. So typically I'll talk about sort of a bifurcated approach in mild or moderate asthma. We've got the options for these medications. They may work, they may not, but if you're at all reticent about putting your kiddo through a surgery, we could try this for 6 months to a year and see if it works. And if it doesn't, the surgery is still an option. I think it's important to kind of let families decide that. And, sometimes you'll see a kid with 4+ tonsils and you're like, I know singular is not going to do anything for you, but if you want to give it a try, it's part of that, partnering kind of process. That being said, I would not offer that for severe apnea, and even more so for severe apnea in a kiddo with obesity or, craniofacial upper airway. But it can be a middle ground for kids whose families want to avoid surgery or maybe aren't ideal surgical candidates.
Have there been any head-to-head studies with the use of nasal, like traditional fluticasone versus acetaminophen?
Not head-to-head that I'm aware of. There have been head-to-head trials looking at different topical nasal steroids, mometasone, fluticasone, et cetera. And there's no clear winner, and montelukast is better than all of them.
Right.
I'm prepared to be wrong about this, but I'm not aware of acetaminophen versus either of these head-to-head.
Okay.
That being said, we will use it off-label if there is a strong kind of allergic component and they've got what looks like adenoid hypertrophy and they've got apnea.
Yeah, I know a lot of ENTs that are using fluticasone and aspirin at the same time, actually for severe cases, and it works pretty well.
Yeah, the one issue there is if it's mostly adenoid, I think that's good.
Right.
If it's mostly tonsil,
not so much.
I mean, no med is going to touch that. But yeah, it is a reasonable middle ground. Coverage can be tricky,
Right.
But I found acetaminophen often better tolerated than fluticasone. It doesn't have that drying sort of steroidy type effect, but if you can get it, use it in conjunction. It's reasonable. Okay, I think, yeah, okay, last slide. There are other treatments out there for pediatric OSA. These are not in the standard care pathway, but they're things that you can consider on a case-by-case basis if the first, second, or third line of treatment is not achieving adequate results. The big issue with all of these things is access. So there's reasonable evidence that a procedure called rapid maxillary expansion, which is an orthodontic procedure targeting basically lateral expansion of the hard palate, can be helpful, especially for those kids we were looking at earlier that have a lot of mouth breathing and had remodeling of their soft palate. Prior to adolescence, that coronal fissure hasn't, or coronal suture hasn't closed, it hasn't ossified, right? So you can use just an orthodontic device, an expander. You can also do it older after it's ossified. That's called a dome distraction osteotomy, maxillary expansion, and then they're actually like cutting that bone, separating it, and then putting in the palate expander. Finding an orthodontist who takes Medicaid who's going to do that is impossible. I'm just going to say that they don't exist. But if you have a motivated family who's willing to private pay, i.e. a Rainbow, not here, it's an option. So there are also mandibular advancement devices, non-invasive dentist-made devices. You'll see these primarily for adults, but they hold the mandible forward And so they move the tongue forward and open up the upper airway. For adolescents, this might be an option. For kids with deciduous teeth and growing mandibles, off the table. There is some limited evidence that myofunctional therapy directed by a speech pathologist can be helpful. Again, access is a problem. There's one group in Akron that I'm aware of that does this. They're the only ones I'm aware of so far. But for kind of for a real anatomic issue where you're trying to remodel the upper airway, induce pharyngeal dilator muscle tone, this can be a helpful thing. I think we maybe send one in here. Last but not least, our ENT colleagues can do a lot more than just a TMA. There are lots of other upper airway surgeries that can be performed, some on the epiglottis, some on the supraglottis, some on the base of the tongue, some on the palate. But any of those you would want to precede with a DICE, drug-induced sleep endoscopy. We've got one or two pediatric sleep docs here at Metro who we share with Rainbow, who are very experienced at sleep endoscopy in kids. That's standard of care in adults before sleep surgery, like before Inspire. But in kids, it's sort of an end-of-the-line therapy to determine anatomic targeting. And what you're looking at here is an example of increasing degrees of obstruction at various points, the adenoids, the soft palate, lateral pharynges, et cetera, et cetera. So, if you're at your wit's end, you've tried everything else, getting the kid back in with ENT for an upper airway evaluation to determine further surgical management is an option. Okay,